This is a live video recording from Radiopedia's 2015 Adult Brain MRI Review course, featuring Dr. Frank Gaylord and Dr. Andrew Dixon. For more information about Radiopedia courses, visit radiopedia.org/courses. If you are showing this video to a group, then please do the right thing and contact events@radiopedia.org to purchase a group license.
Originally the plan was for, when we devised this, it was going to be Dixon and Gaylord both presenting kind of an equal share of the content, but it became apparent very quickly that Frank knows a hell of a lot more about neuroradiology than I do. So he's going to present all of the teaching content, and my role is going to be to present a little session recap at the end of each hour, so 10 minutes at the end of each hour. And that recap, I'm going to try and highlight some of the points that I think that the non-guru can take away from today's event. I'm going to try and emphasise some key points. Also, I'm going to try and wake you up, because it is hard spending a whole day inside a fairly dark room. So when I do my recap, the lights will come up and we'll give you a little chance to kind of refresh your brain and get ready for the next session. It's also going to be a little bit interactive, nowhere near as interactive as that table. If you send any feedback, any questions, little quotes about things you've picked up along the way, send them in, and I will incorporate them into my recap. I'm coming up with my recap live, so I'm watching Frank's presentation, and I'm going to choose some of his slides, add in a few of my own cases. So it's a dynamic kind of process, the recap. So if you can send me something, that would be fantastic.
All right, so session one, we're dividing today in a whole bunch of about 25-minute review topics, and we're going to start with two pretty hefty topics which lay down some groundwork for the rest of the day, and extraaxial masses is our first one. So we can divide extraaxial masses into the usual tumours, cysts, vascular lesions. A lot of these slides have this sort of sign that tells you that I haven't forgotten. It's going to be discussed later on today because there's a lot of overlap. And remember, sit there and just sort of let it wash over you. Take notes if you want, but all of this will be available to you recorded, so you can go back over it. All the slides are already available to you. You can look at every single case in complete format when you want to get back to it. So let's start with extraaxial tumours. We all know about meningioma, and there are a bunch of other meningioma sort of lookalikes. There are a few tips that can help you decide whether or not to include them in your differential. And then there's a bunch of tumour-like conditions that can mimic meningiomas. And again, there's a couple of key features that are helpful in smelling a rat. Starting with meningioma, it's one of our favourite tumours. We see so much of it, and we usually get them right, both because it's so common and because the imaging characteristics are so characteristic. So here we have a large mass, which we can tell is extraaxial because of a number of features. First of all, we have this CSF cleft, which is CSF or fluid trapped between the tumour and the adjacent brain. And you can see the effect it has on the adjacent brain is to compress the white matter. In older textbooks, this is referred to as the white matter buckling sign, which I think was really when you couldn't see it very well. It was helpful. Rather than expanding the gyrus, it would compress it. Something that's really important to note about CSF cleft sign is that on flare, it doesn't necessarily follow CSF. In this case, it does here, but if you come across here, it seems to be hyper-intense. And that's just because there's a bit of tumour juice mixed in with the CSF, making it not attenuate fully. The other thing you'll notice is that trapped between the cortex and the mass are vessels, because meningiomas arise from the arachnoid cap cells, so they're abutting the dura, pushing the pia away, and therefore pushing the subarachnoid space away, which contains the cortical vessels. And so intervening pial vessels is a very useful sign. And note the anterocerebral arteries are displaced posteriorly here. The other thing meningiomas do is that they start in one little spot, down here in this case, on the planum sphenoidale, and as they grow, they bring with them their arterial supply. And so when you cut through it axially, axial to the tumour, you can see this spoke wheel appearance as it comes from where it originated, radiating out along with the meningioma. Whereas in sagittal or coronal section, it'll have this sort of sunburst appearance coming up forward. And this will be the place where you see most of your hyperostosis, because that's where the tumour has been there for longest. Typically, the enhancement is very vivid, very homogeneous, The vast majority of meningiomas are just solidly enhancing very brightly without cysts or areas of non-enhancement. They usually follow grey matter on both T1 and T2. Now, a differential for this anterior cranial fossa meningioma would be an esthesioneuroblastoma, which is a tumour of the olfactory epithelium. Note how in this case it's gone through bone and it's destroyed the bone, and almost invariably esthesioneuroblastomas have a significant nasal component. So that's something that's helpful. And here you'd be tempted to say, well, the epicentre of this mass is on the cribriform plate, which is true, but the epicentre is a terrible marker of whether a mass has arisen from a particular structure in the brain if it doesn't destroy bone. So any mass that pushes against the bone, as it grows, the epicentre here in yellow will gradually displace centrally. So you can't judge the site of origin of intracranial tumours when they're large based on their epicentre, which is different to tumours in the rest of the body largely, where they grow spherically from the site that they originate. Another sign that's not very useful, or is useful only because statistically meningiomas are so very common, is the dural tail. And we love to talk about dural tail as being part of the meningioma. In fact, most dural tails don't have any tumour in them, and the surgical literature's divided as to how much of the adjacent dura you need to resect. When you biopsy the dural tail itself, in the majority of tumours, there's no tumour cells. It's reactive edema of the adjacent dura, which also makes sense because meningiomas don't arise from the dura itself. They arise from the arachnoid that's abutting the dura. But we see dural tails in a variety of other tumours, including intraaxial tumours. So in this case, a glioblastoma. This is a rare manifestation of glioblastomas, but cortical tumours can incite a reaction in the adjacent dura. And pleomorphic xanthostrocytoma, which we'll see in the epilepsy talk, is the classic tumour to do this. And of course, any infiltrating mass. So in this case, it's lymphocytic hypophysitis, and we can see that there's reactive dural enhancement. So these are all signs that you put together to decide whether something's intra or extraaxial, but you can't rely on one in isolation. There's only a few conditions where CT is better than MR for imaging tumours and tumour-like conditions. And one of them is where there's a lot of calcification. And you do get this entity that's sometimes referred to as a burnt-out meningioma, where the entire meningioma has ossified or calcified. And it's very easy to spot. And this is a very classic location for them, anterior middle cranial fossa. On MR, it's just dark on everything. You might get a little rim of enhancement. And when reporting these, I think it's really important to concentrate on the enhancing non-calcified component, because it's this component that has the propensity to grow. If it's entirely ossified like this, the chances of this meningioma growing are about as much as another piece of dura somewhere else in a patient who doesn't have a meningioma growing. And I think we follow these up obsessively for much longer than they need to be followed up, especially in elderly patients. So meningiomas sometimes, though, don't look all that quiescent, and they can go through bone. Sometimes they can be entirely intraosseous and just appear as an expanded enhancing region of sclerotic bone. But occasionally they go through. But one of the things that meningiomas tend to do is they go through, leaving behind a ghost of what structures they've transgressed. So here we can see bone left over. It's gone through into the subgaleal tissues. And here you can even see the dura itself. That's probably the parietal, so endosteal layer, as a black line. And we'll see this repeatedly, that meningiomas have the dura going through it, which, if you don't remember that meningiomas are not actually of the dura but of the arachnoid, can be a little bit difficult to explain away. Whenever reporting a meningioma, you have to really look carefully at the overlying bone, because identifying bony involvement means that for the surgeons, they'll usually throw away that bit of bone and perform a cranioplasty rather than put the bone back. And looking on fat-saturated post-contrast T1 for enhancement of the marrow, and on non-contrast T1 is particularly helpful in seeing involvement. Hemangiopericytomas, on the other hand, are the tumour that's much more likely to go through bone. And when it goes through bone, it destroys bone. It doesn't infiltrate it, it doesn't make it sclerotic. The bone just ceases to exist. And this is one of the features that would make me put hemangiopericytoma in the differential, and only really when it looks like this would I think about putting it number one, because it is an uncommon lesion, and most of the time it'll be a funny looking meningioma. But there's another few features here that are helpful in distinguishing hemangiopericytoma from a meningioma. And that's the pattern of vascularity. If you remember, we saw that sunspoke appearance as it grew away from the dura. That's usually absent in hemangiopericystoma, with vessels being predominantly seen around the periphery, being parasitized and growing into the tumour. The bone's completely absent. It tends to be more lobulated than a meningioma. Meningioma is usually one lump or maybe a few broad lumps, whereas hemangiopericitomas have this highly convoluted surface, and they're much more aggressive. And when they go through dura, unlike meningioma where you often see the black line of the dura remaining, the dura is just gone, just as is bone. Having said that, we are lulled into a false sense of security with meningiomas because they all seem to look the same, but there are a number of variants that you need to be aware of. So the first one is that meningiomas can on occasion be cystic, and there's sort of 4 types of cysts that you can see with meningiomas. The first one is a meningioma that doesn't enhance completely and has lots of small cysts in them. This is not microcystic, it's just small cysts. The other pattern, which you see not infrequently, is a sort of rosary bead of cysts at the periphery of the tumour, with tumour extending all the way around the cyst. So these cysts are within the tumour, they're organised around the periphery. And when reporting this, it's important to look for this enhancing component, because surgically this is tumour and needs to come out if possible. Whereas in the third type, where you have a peritumoral cyst, you're just having an arachnoid cyst or a pocket of CSF that keeps accumulating and pushes the brain away, but is not related to the tumour itself, and nothing needs to be done about this wall. You can just carve away the meningioma itself. The fourth type of cystic meningioma that's a little bit less common still and harder to remember about because it looks so different to a meningioma is a microcystic meningioma. And the cysts are microscopic, so you won't see them, but they'll manifest as very high T2 signal, just as here. In some instances, they're so cystic that there's not much enhancement. Often they're very high in T2, but still very vascular and very enhancing. And so you have something that looks like a meningioma, except it's very high on T2. It's worth remembering not only so that you get the diagnosis right, but because these meningiomas have a tendency to be very, very vascular, and so surgically they can pose problems with intravascular hemorrhage. On diffusion weighted, on ADC, you'll see facilitated diffusion because they're so fluid rich. At the other end of the T2 spectrum are masses that look like meningiomas but are very dark on T2, and these are solitary fibrous tumours. Very difficult to distinguish on any sequence except for T2, where they characteristically have this fibrous sort of signal, which is low on all sequences, but particularly T2. Another beautiful CSF cleft sign with an intervening artery caught between them. And they enhance very vividly as well. Histologically, they're thought to probably represent a spectrum of disease with fibrous tumours of the dura at one end and hemangiopericitomas at the other. Even though they behave very differently and look differently, there's thought that they actually represent the one pathology. There's only one other case really that has this very profound T2 hypointensity, and that's a non-tumour. It's a non-Langerhans cell histiocytosis called Erdheim-Chester disease, which can affect the whole body, so musculoskeletal particularly, but it can involve in organs and the dura. And when it does involve the dura, it tends to have this very lobulated, multifocal sort of lumpy, very low on T2. It has also a predilection for the orbits. So this is actually quite hard to see because it involves the whole orbit, but all the retroorbital fat is displaced by this low T2 mass, which is fairly characteristic of Erdheim-Chester as well. You don't see this very often. We would see this maybe once every 5 years. So don't hold your breath and don't start calling it, saying Frank told me so. Another condition to always keep in mind if what you're going to talk about is en plaque meningioma is could this be leptomeningeal carcinomatosis or pachymeningeal metastases. Breast cancer would be most common. Tuberculous pachymeningitis can have a very similar appearance but tends to have a lot more edema associated with it. And here we can see very long, thick, only somewhat nodular dural thickening, and sometimes it can be just a solitary dural mass that presents as a dural metastasis, almost indistinguishable from a meningioma. So now moving away from our masses and looking more at cysts or extraaxial cysts, there's only a couple that I'm going to talk about in this lecture, and arachnoid cysts I think are really important to be aware of and have a few ways of distinguishing small arachnoid cysts from enlarged CSF spaces. Now, my advice to you is this: if you're not sure whether it's an arachnoid cyst or an enlarged CSF space, don't mention it and call it an enlarged CSF space, because the moment you label it an arachnoid cyst, 1 in 10 patients will become very concerned and very scared by the fact that they have a cyst, and will begin to attribute all kinds of symptoms to this 1 centimetre arachnoid cyst. And the vast majority of these are asymptomatic entirely. There are some that aren't. So some headaches do get better when you drain them. Sometimes they have a lot of mass effect, but the vast majority are entirely asymptomatic and incidental, and you're probably doing your patient a favour by not mentioning it and let it slide if you can. And play it down and make sure it's not alarming, the language that you use. When they're larger, you can't help but mention them, and this is a typical location for an arachnoid cyst. Middle cranial fossa extending into the sylvian fissure and widening it. And note how it remodels and scallops the bone. And this is merely due to the fact that this is a almost spherical pocket of incompressible fluid. And every time you have a cardiac systole, the brain expands and pushes the cyst up against the bone, and over years that's enough to remodel it. CT will show that this is very, very thinned, almost dehiscent in places. Importantly, because it's a cyst, you won't see any vessels running through it. So that's a helpful distinguishing feature between an arachnoid cyst and an enlarged CSF space, because the vessels will be pushed away from the CSF, from the arachnoid cyst margins. The other thing that can be seen, especially in smaller cysts, is they're hyper intense to normal CSF. And that's not because the CSF inside them is somehow different. It's that normal CSF has to and fro pulsation during the cardiac cycle, which on T2 will cause it to lose some signal. You can see that here in the frontal horns. You can see this slight blooming loss of signal due to CSF having jetted through the foramen of Monro. Because CSF is confined to the arachnoid cyst, it won't have that as much. You might get some turbulent flow maybe, but usually it'll remain very homogeneously hyperintense. This is particularly helpful in the spine, where in the posterior to the thoracic cord, where you get a spinal arachnoid cyst, there's usually a lot of pulsation artifact, and seeing lack of that extending through is a very helpful sign. But it can also be useful in intracranial compartment. It'll follow CSF on absolutely every sequence, and that's critical, including diffusion weighted. There's not much really that can mimic that other than not a cyst filled with CSF, but an arachnoid, an epidermoid cyst can sometimes look similar. And I think the literature talks about this as if it's a bigger diagnostic dilemma than it actually is, because modern imaging can just tell them apart fairly easily. They can look very similar to CSF on CT, but modern CT, where you don't have as much streak artifact, usually you can see that there's some heterogeneity to the signal, which doesn't quite follow CSF. And on T2, again, we can see that it's not quite as clean as you'd expect it to be. The other feature is that it has this scalloped border. It tends to insinuate into compartments and wrap around vascular and neural structures, making them very hard to fully resect. On FLAIR, it does not follow CSF exactly. It has a very dirty appearance. It depends how you perform your FLAIR. So this is a standard 4mm thick slice where it kind of does a better job of looking like CSF, but on volumetric studies it really does look very dirty. But if you're in any doubt, diffusion weighted imaging is the one that will help you, because epidermoid cysts have this characteristic extremely bright signal on DWI, which on ADC is about iso-intense to brain. So it restricts a lot compared to arachnoid cysts. It restricts about as much as normal brain. So the distinguishing feature is between arachnoid cysts and epidermoid cysts. So don't get disheartened by the fact that on ADC it doesn't look black. It's still restricting much more than CSF does. So that's a whirlwind tool of extra axial masses.